afternoon, and welcome to today's webinar, Traumatic Brain Injury and Neurodevelopment, Impact Diagnostic Issues and Treatment. Thank you for joining us. My name is Kim Stranero, and I am a Community Outreach Specialist at the Brain Injury Alliance of New Jersey. The Alliance is a nonprofit organization with a mission to provide education, awareness, prevention strategies, advocacy, and support for those who have been affected by brain injury. I would like to announce that we will be hosting another webinar on May 19th, 2025 on traumatic brain injury in service members and veterans. More details will be coming in the next few weeks, so stay tuned. Just a few housekeeping notes before we begin the presentation. Attendees' microphones have been muted, so if you do have any questions during today's webinar, please type them in the Q&A box at the bottom of the screen. We will get to as many questions as possible at the end of the presentation. This webinar is being recorded and it will be available for viewing on the BIANJ website. At the end of the webinar, a link for a post-webinar survey will be placed in the chat. We do value your feedback, so you're encouraged to complete the survey. You must complete the survey in order to receive your certificate of attendance. Once you do complete the survey, you'll automatically receive your certificate of attendance via email. So without further ado, our presenters for today's webinar are Dr. Hilary Murphy and Dr. Christina Speranza. Hilary Murphy, PhD, is a licensed clinical psychologist and clinical neuropsychologist with a specialization in the assessment of neurodevelopmental and neuromedical disorders. Her training in school psychology provides her with expertise in collaborating and consulting with educators and other professionals to develop comprehensive, individualized educational and treatment plans. Her areas of expertise include attention deficit hyperactivity disorder, ADHD, specific learning disabilities, traumatic brain injury, concussion, epilepsy, stroke, and developmental disabilities. And then our other presenter for today, Dr. Christina Speranza, is a licensed psychologist and formally trained neuropsychologist, focusing on clinical evaluations of toddlers, school-aged children, adolescents, and young adults with neurodevelopmental disorders and comorbid concerns, such as emotional difficulties, behavioral challenges, or medical conditions. Areas of clinical interest and expertise include attention deficit hyperactivity disorder, ADHD, autism spectrum disorder, specific learning disorders, intellectual disability, communication disorders, executive functions, anxiety, depression, disruptive behaviors, and adaptive skills. Dr. Speranza is formally trained on the Autism Diagnostic Interview Revised, ADIR, and on the Autism Diagnostic Observation Schedule, ADOS2, across the lifespan. She also has experience providing executive functioning coaching to middle school, high school, and college students. I'm so pleased to welcome Dr. Murphy and Dr. Speranza.
Thank you so much for such a warm welcome. I'm so excited to be able to talk about this with everybody today. And Dr. Speranza and I really tried to collaborate and create what we think is the most comprehensive kind of presentation that we can provide within the time limits that are given, because this is a really, a dense topic, if you will. There's so many different elements that, any of you who are incredibly experienced in working with this population know there are socioeconomic factors. There's all of these, kind of developmental factors. And so as a result, we really tried to hone in on two of the most common neurodevelopmental issues, both ADHD and autism spectrum disorder, and essentially talk about how these two disorders kind of function alongside and in the context of individuals who also have a history of TBI. Now, again, kind of looking at some of the kind of definitions, the course here, we know these are acquired injuries. And one of the reasons that it can make it kind of sticky, as you're going to see as we start talking diagnostically, is the fact that when these kind of injuries or acquired illnesses occur during the developmental period, it can make it very, very challenging for us to really be straightforward about whether this is a developmental disorder or whether this is secondary to the injury. And the reason is because they're occurring at the same time. If you have an acquired injury that happens during the early developmental period, well, then it's really hard for me to say, okay, like, is this something that was due to that? Was it coming anyway? Or is it secondary to this kind of other complicating factor of this injury that occurred? And again, in some instances, that can be important, not just because we like to be accurate in what we're calling something, but it may potentially change the outcome that we might expect and also the way that we handle some of these diagnoses. There's a reason that we can get really stuck on some of what seem like these very small details. Now, obviously, we know that within that first 12-month period, that is the greatest period where we're going to see the most gains. And particularly in children, it's important that we are intervening just as intensively, just as quickly as we would with adults. Now, a lot of times there's this kind of misnomer that people will have of like, oh, after that point, sort of like we hit that 12-month window, and then all of a sudden the trajectory stops. It's not that we stop making progress, but that the trajectory of the progress is a lot less intense. It kind of starts to plateau, meaning that we're not going to see as rapid or as many gains as we might anticipate. Now, when we think about functional outcomes, which really is one of the biggest things that we're trying to understand for individuals who may have a history of TBI or any of these developmental issues, we talk about outcomes no matter what the issue is itself. We know that there's so many different elements here. It's like I mentioned, there's these socioeconomic pieces. There are, these kind of characteristics of the injury itself. There are social determinants of health, which we're going to briefly talk a little bit about in a few minutes. And so again, we have to be very careful and thoughtful. And remember, this is a really individualized approach. Every case that we see is going to have its unique characteristics. And the reason that I really kind of point this out is that we certainly have to take into consideration all of the very particular variables that any individual this next stage of recovery. Again, we used to think that injury severity was the biggest feature that would predict outcomes, and now we know it's far more, expansive than that, that there can be the availability of a lot of these supports and all of these other kind of more social emotional factors, many of which, especially for children, which is really the big kind of focus of our discussion today, maybe outside of a kind of their kind of control, and again, still have a really important impact on them. We also have to remember that TBIs tend not to occur necessarily in kind of a vacuum, right? We know that oftentimes there can be other orthopedic injuries that occur. And so the nature of like how this injury, happened, was it a motor vehicle accident? Was it the result of kind of domestic violence or an assault or any of these other things? All of this is going to be incredibly important in understanding and starting to talk about what are some of the areas specifically that we need to intervene with or understand for this individual. Now, one of the things I like to talk about right at the kind of get-go, whenever we're kind of discussing working with children, is this idea of like bouncing back. Because years ago, it was really sort of this thought of like the earlier that you acquire this injury, almost like the better off you might be because of neuroplasticity, right? And we
Dr.
do,
Murphy, sorry to
yes.
interrupt. I can't see your slides. I'm not sure if you're sharing them at the moment.
Oh, I am so sorry about that. Let's see what
No, no worries.
happened.
I wasn't
All
sure
right.
whether you had an intro without slides or
Nope, nope.
meant
I
to.
should have been sharing. That was my problem. Give me one moment. There we go. We good to go?
Perfect. Yep, looks great.
Oh, I apologize for everybody. You missed all of the funny little slides I had before. Don't worry, they'll be available as handouts, so not a big deal. Excellent. So one of the things that I like to kind of point out here is the fact that for many instances and for many individuals, there's this idea that because we have plasticity, we're far more likely to see kind of a better outcome. And we know that unfortunately, researchers haven't really, this in the context of TBI. Again, it is not to say that neuroplasticity isn't a factor in some of these kind of injuries, that we actually see for many children is this phenomenon of a child growing into the deficit. And what I mean by that, and one of the things that's going to be very particularly a section of the talk where we're focusing a lot on ADHD, is the fact that growing into the deficit means that a child, due to the nature of their injury, is issues in skills like attention or executive functioning that they might not be required to demonstrate yet. So I like to give the example of a child maybe who is 3 or 4 when they suffer maybe a more moderate to severe injury. As things stabilize and we start to see some of the areas of their functioning, kind of plateauing, as I mentioned before, we might see that they make pretty tremendous gains. And then over time, as they kind of get into early or middle elementary school, all of a sudden their attention really seems to be lagging. Maybe it was a little weak before, but now it's really pronounced, or they start to be incredibly disorganized, or they can't inhibit themselves, they can't regulate their behavior. And parents will say to themselves, and clinicians will say to themselves, oh my goodness, could this essentially a reflection of like ADHD, or is it due to the injury? And this idea of growing into the deficits would say that we know that attention and executive deficits are very, very fundamental, very common in these types of injuries. And rather than saying that it's sort of a new onset, it may be that this was something that was damaged very early on. So secondary to the injury, we're only noticing it now because this is when we expect that child to demonstrate these skills. We talk a lot, about demands being quite low at certain ages. So again, I like to talk about this idea of growing into the deficit because this is also where it makes it very sticky diagnostically. And we'd also talk about, the fact that there are all of these, kind of more physical factors, clinical management, what were the kind of rehabilitative supports the child gave? We have to, whether we like it or not, accept that there are certain, determinants of health, which we're going to talk about in a moment, that are outside of a child's control, but that have a really significant impact on how they recover from a given injury. The availability of something like very good insurance, having adequate coverage to stay in rehabilitation as long as clinically needed. Also, we know that fit larger heads, they have weaker neck muscles. This puts increased risk just at baseline for cranial injuries. And we also know that when a child is injured at key points in development, they can again have a disruption in really like kind of long-standing trajectories of where they could be, or kind of what they can do, because it disrupts the normal kind of curve, if you will, the normal curve of where they should be going, how they are meeting or keeping up with the trajectory of their peers. Moreover, there can be things like the financial burden. Again, kind of going back to that insurance issue, we certainly know that the availability of economic resources or lack thereof is going to significantly impact whether or not a child gets adequate inpatient or outpatient care. And that's going to have a very significant impact on what they look like after the injury. Now, we do know that there are certain determinants, whether they are modifiable, meaning these are things in our control. We can move locations, we can learn new languages, we can increase education. But one of the things that we know is that these are things that don't tend to, be changed right away. These are things that change sort of over generations, over lifetimes. And we have ones that are not within our power to change or control, like our race or our ethnicity. And all of these things have been found over time to have a significant impact on our recovery from any kind of injury, particularly in TBI. You may be very familiar with the term of adverse childhood experiences. This is another kind of social determinant of health that's really important in understanding how individuals may fare after the injury that they sustain, and also may even impact the nature of the injury that they acquire. So we know that certain individuals from different racial groups may be more likely to sustain an injury secondary to violence. We know that some individuals are more likely to sustain an injury secondary to motor vehicle accidents. These are some of the conditions that I think are important for us to be aware of. And we know that can impact the availability of their care, as I mentioned before. We think about like language barriers here. In many instances, what we see is that the materials educationally that are provided may not be translated and available and tangible to the family in a way that makes sense, that makes them useful. Essentially, they're just not providing the kind of services that we are expecting from some of these handouts that oftentimes people take a tremendous amount of time in, creating or tailoring, and that we rely on to convey or back up some of the information that we're providing our clients. Like, we are limited by time, we're limited by our caseload. In so many instances, we're limited by the fact that we are also medically bilingual. We are talking about and using the jargon or language that is really related to our personal kind of profession. very easy for us to forget that not every single person knows what we're talking about when we're using some of these very specific terms. So even like neurodevelopmental disorder, or some of the things that we'll be talking about today, again, it's really, really important for us to remember that those are not always words or phrases that have a tremendous amount of meaning or have the same meaning for an individual who's not kind of aligned in the same kind of profession that we are. Now, again, we know that certain, individuals of color, they're more likely to have longer hospital stays. They're more likely to have greater inpatient costs. They're likely to have higher rates of complications. And so as a result, all of these other kind of financial barriers have to be, understood as preventing families from being able to provide, in some instances, the most appropriate care for their kiddos. And as a result, we're likely to see this mixed bag, some of these general outcomes. Now, we've talked a little bit about this, so I would like to kind of move on in terms of what we're thinking about with respect to how like neuropsychology can be helpful. And I always like to talk about this. One of my favorite jokes when I have a new person come into my office is like, did anybody ever tell you like what a neuropsychologist is? And more often than not, and I'm sure Dr. Sprazza can relate to this, we sort of get like a little like, oh, I'm not too sure. I usually will say, oh, if you ask anybody in my family, they'll be like, Hillary talks to people, and that's about the extent, and understandably so. Like, again, I don't expect anybody to know some of the nitty gritty of my profession. But the reason that neuropsychologists can be so incredibly helpful here is that it is our job to understand brain behavior relationships. We try to use all of the data that we gather from these assessments that we're going to be talking about in a few minutes to understand not only where was somebody before the injury. We can develop these estimates of what we call premorbid functioning. There are certain cognitive tasks or abilities, again, that can be used in some instances to give us a rough estimate so that we can compare and say, is this person kind of below? Has there been a change in their functioning after this injury? Again, can help with some of that diagnostic clarity. But we also can track their progress and we can identify where are the deficits. There's a lot of information about what we expect given certain kinds of deficits in specific populations that are really helpful for us in, being able to develop, really specific treatment plans, whether it's a return to school, whether it's a recommendation to other clinicians in the area, like occupational therapists, speech therapists, or other more specialized therapies. And also we can use some of the serial assessment to track progress over time. We have very specific measures that are meant to be used. And we can then say with a lot of certainty, this is someone that's making this really tangible progress. But again, these, we have to take them with a grain of salt. We have to remember that there are all of these other factors, like the example of orthopedic injuries. Well, some of our measures, let's say, of like processing speed or just the speed with which you take in information, well, that's going to be impacted if, let's say, there was a tremendous amount of damage to your dominant hand. I might not be able to get a very good estimate necessarily of your processing speed. I may be documenting more of your motor limitations, or we know that fatigue and kind of cognitive stamina oftentimes can be, restricted after an injury like this. So sleep disruptions are incredibly common. I may be capturing more of a person's fatigue than I am other aspects of their cognitive functioning. So again, these are not perfect, but they, again, are materials and kind of ways that we can put numbers and kind of quantify some of these really, kind of complex behaviors. And these are some of the ones that we anticipate seeing some challenges in after an acquired injury like a TBI. So we would expect with respect to language, usually we think about these more like kind of rote skills, your vocabulary or just basic comprehension tend to, in many instances, be somewhat intact over time, with the exception of some pragmatics. Again, every injury is a little bit different. These are kind of broad rules. We know visual spatially, sometimes this is really impacted by some of those motor or speed issues that I mentioned a few minutes ago. We see that memory, this is one that can be a little tricky to assess for us simply because it is highly tied to attention and executive functioning, which is what I'm going to get to in a minute. If we see that attention or executive functioning skills are impacted, it's very possible that we're going to see that memory is impacted also. Now, when we think about like kind of TBI and ADHD, there's a few elements that make it really hard to say what is the chicken or the egg. We do know that documented histories of ADHD can potentially greater risk for sustaining different injuries. Again, I think of some of the characteristics that some of our clients, our parents will sort of talk about. Let's say my child is fearless, my child acts impulsively, my child doesn't think things through, they're a risk taker. Having some of those characteristics could put you at risk for sustaining an injury. And we also know, unfortunately, if let's say we have an injury during a really kind of key point in development, and we know that attentional and executive weaknesses are extreme this population post TBI, well, it starts to become really challenging to know which happened first. Was this ADHD going to develop over time? And then it just happened to be that this person had a TBI? Or is this something that's a little bit more kind of new and novel? And again, this is where getting a really good family history, really trying to understand an individual before, and again, kind of going back to that pre-morbid functioning that I mentioned, pre-injury functioning is extremely important. It's something that we encompass or kind of like really try to build in any of our evaluations that can be very, very helpful in teasing some of this out. Now, again, it is important to note that what some of the more recent kind of like meta-analyses, some of the research kind of coming out talking about what does this look like after injury, more mild or TBIs kind of really used interchangeably with the term concussion, doesn't seem to be related to an increased risk of attentional or executive deficits over time, particularly in individuals who did not have a history of that to begin with. But not all MTBIs or concussions are the same. There are some that are far more serious than others. And this is what also can make this a little bit sticky, is that definitely will use these kind of like umbrella terms that encompass very, different manifestations of kind of these injuries. So you could potentially, have been struck by a bus and be diagnosed with a concussion or an MTBI. You could, head a ball a little bit too hard in soccer and have the same diagnosis. And so again, there's some issues here, and this is where we have to recognize that some of our systems are not perfect in really teasing out the little kind of minute strings of these issues that I think can make it really hard here. Now, when I talk about like attention and executive functioning, what we know is that for many individuals where the attentional issues appear to be secondary to a TBI, they are sort of particularly in more moderate to severe injuries where we would expect more longer lasting issues. We usually will see this kind of different kind of cascade of skills that are impacted. Basic attention is something that tends to come back online to a certain extent. And again, we think about attention as being this one thing, it's just focus. But in reality, it's not just being able to kind of hone in on one topic. It's also about being able to ignore anything else in our environment that's really not salient. So you might be listening to this talk, and let's say you have a coworker next door that's working on something, you can kind of hear them shuffling around in their office. You're not even thinking about how you're inhibiting or kind of ignoring that piece of stimulation because you're like, that's not what I want to pay attention to now. What can happen for a lot of individuals is that their brains start to have difficulty with that filter. They can't always determine what is important in my environment, becomes a lot more effortful. So if we think about the idea of like cognitive fatigue, or people saying like, oh, it takes me so much more to do something that I could do very easily previously, that's part of what we're talking about here. We see individuals get very dysregulated. So emotional dysregulation, these personality changes. And this can range from a person seeming very depressed, flat, or not having any interest or motivation to being very reactive, very, impulsive, which is a very different kind of expression. Again, we can see, particularly in that more impulsive or dysregulated example, the same thing in individuals with ADHD, especially over time. Working memory skills, just being able to remember things for a brief period of time, doing mental operations like a mental math problem can be very, very challenging, tends to have a lot of significant effects on kind of academic performance. They're not always able to use feedback. So one of the things that Dr. Sparazza is going to talk about is this, kind of profile of social and interpersonal challenges that can be faced by individuals who have a history of TBI. And we know one element of it is like not being necessarily able to read the room effectively, but also not taking feedback from our environment to guide our behavior. If people are giving us subtle signals that they don't like what we're doing, that we're too loud, we're too close, we might not know that that's the message they're sending until they blatantly tell us. And usually by that point, the person is upset. So now we're going to have a social interpersonal difficulty. We might not be able to kind of set things up to get to our goals. And these are all issues that honestly we would expect to hear from any kind of person with a question of ADHD. It really starts to come down to kind of when exactly we started seeing these difficulties, the nature of them, and also like, do we have any element of history that could help us to flesh this out? And I talk a lot about the idea of history because not only do we know that a genetic history of ADHD, okay, that's going to raise, the likelihood, the possibility that a person could have had a pre-existing kind of history of ADHD, which might change how we approach their diagnosis or their treatment. But also, the family dynamics may be impacted here. A lot of executive kind of coaching skills, a lot of the things that, or I should say, not necessarily executive coaching skills, but executive functioning skills, I'm sorry, these are things that are built. They are essentially modeled for us, demonstrated, and then reinforced over time. But if we have a family home where perhaps we have a parent or both parents who have a little bit of executive dysfunction, it's going to be harder. Family relationships tend to be a little bit more chaotic. They can be a little hot and cold. There can be a lot of stress because, we're always running out at the last minute. We're forgetting things. Everybody is a little disorganized. And that can, again, kind of feed into this sort of learned behavior because that becomes our normal. We don't see other examples of people being very organized, and our families may really struggle with that. Add on top of that the fact that there can be a true caregiver burden. So I mentioned those financial burdens that can happen, but also shifts in family status where perhaps one parent really takes on that caregiver role for a child who is really struggling tremendously and perhaps has lost certain skills. That's something that can, again, contribute to things like burnout, frustration, resentment. It is going to cause turmoil in the family. And we know any level of emotional stress, it is going to then impact our ability to focus, pay attention, and organize ourselves. So you can see all of these things really kind of culminating together. And I think that leads us then nicely into the part of the discussion with Dr. Sparazza, kind of, picking up on autism as well as aspects of kind of social emotional functioning. So I'll turn it over to you, Dr. Sparazza.
Thank you very much. So in terms of autism is one of the populations actually that has an increased risk of particularly mild TBIs. And we'll talk a little bit about why that is as we're going through this. And also, certainly there's many features of autism that can overlap with presentations of TBIs. And we'll talk a little bit about some of the most common findings on our neuropsych testing and ways to help kind of differentiate the two. Because like Dr. Murphy said earlier, we always want to be accurate in our diagnoses as often as we can, but also the goal of having a diagnosis is to then help drive interventions and better understand where a person's coming from and the steps moving forward. Next slide, please. So one piece related to both autism and TBIs is this idea of adaptive functioning and social functioning. And we'll talk about them each separately, but also together. But certainly, research has shown that a lot of individuals, especially with more of those severe TBI presentations, are at greater risk for impairments in adaptive skills. We'll get into the definition a little bit more specifically in a little bit, but adaptive abilities are essentially the skills that we all have in terms of being able to care for ourselves, manage tasks on a day-to-day basis, and show some responsibility for ourselves, whether it's here at home, in our community, in school. And adaptive functioning is developmental, which means that at every point in our life, there's going to be different expectations. So certainly the expectations that we'd have for a toddler, for example, or a preschooler are much different than for a school-age child or a high schooler or a grown adult. Also, individuals with autism, as we know, there are social differences, and individuals who have sustained TBIs, there could be social isolation as a consequence related to their injury. This could be them in a rehab center. This could be a lack of social support, and that then can lead to social difficulties and further impact their social functioning in that regard. The two together certainly can also exacerbate or lead to mood-related concerns. That's what this kind of, the next few slides are going to kind of talk about, and we'll parse them out separately. So if you don't mind going to the next slide, we're going to talk a little bit about the social piece first. So like I was mentioning before, certainly social challenges are present in both autism and TBIs. especially as individuals get older and we're thinking about whether this was a sustained TBI when kids were younger or if they're a young adult. This could impact certainly, their friendships, their ability to get jobs and be employed. It can have educational impacts as well, and just overall a reduced quality of life. Similarly with autism, certainly depending on in terms of the level and the support that's needed, some individuals with autism are not able to independently, live on their own or sustain a job, especially if you think about something full-time with a lot of people around. So those can certainly be some of those outcomes. And then again, comorbid conditions, things like anxiety or depression, can exacerbate some of these outcomes that we already know they're vulnerable to. Next slide, please. Beautiful. So we'll first start with autism specifically and talk a little bit about the criteria briefly. So for autism, the two domains that we're looking is social communication and interactions first. So things that we'll see here are perhaps some subtle differences in their communication styles. This could be verbally and non-verbally. So content, things that they like to talk about, whether it's related only to their interests. We're looking at reciprocity, their use of gestures and eye contacts, being able to relate to others emotionally, understanding others' perspectives. The second part is what we call these RRBs, or restricted and repetitive patterns of behaviors. And these include things like sensory sensitivities or seeking behaviors, narrow interests or unusual interests, any repetitive movements behaviorally or with objects, or even with speech, and also like this rigidity with like either schedules, routines, needing things done to be in very particular ways. Now, a lot of these signs, typically do emerge in early developmental period, but like Dr. Murphy said, if during that time a TBI was sustained, it can be difficult to kind of tease apart. So especially our job as neuropsychologists is to get a really good, thorough developmental history and kind of get a sense of when some of these things, even if it's in hindsight, when the onset was. But a lot of times too, we see presentations, especially for autism in particular, where maybe there were some subtle signs or features when kids were younger, like in the preschool years or as a toddler. But as they've gotten older and now they're school-age children or middle-age, or sometimes we even get high schoolers coming to us for the first time, those social differences really are noticeable because social demands have increased over time, and it's just gotten to a point where they can't sustain it anymore. So that certainly is always something that we're taking into consideration. But again, like I mentioned, history and timeline are really important in trying to tease some of these things apart, especially when a head injury occurred early on. Now, in terms of most recent prevalence rates with autism, we know that that is on the rise, and autism is also associated with a lot of different common conditions, one of which is epilepsy. And individuals with epilepsy, we already know, are also at a high increased risk for TBIs or head injuries. And that's also something that we take into consideration because certainly epilepsy on its own can impact neuropsych findings. We always want to take that part into consideration. Now, when we have a presentation of autism and TBIs, we are always looking at first, certainly the overlap between the two. So certainly, autism and TBIs, depending too on the areas that are impacted in the TBI of the brain, certainly, one thing we want to look at is their communication skills, social communication skills. A lot of times the presentations of both autism and individuals who have a TBI but don't have autism have this limited social awareness. They have a lot of trouble kind of with perspective taking, their social emotion relations with each other, picking up even on certain cues, but to varying degrees, and that's where the difference lies. So individuals with autism tend to have a lot more trouble picking up on more of those less or trying to pick up on anything that's not as simple or as obvious. So even something that's a little subtle or ambiguous, they would have difficulty picking up on something like that. Individuals with TBIs are able to pick up on those simple cues, but they have trouble more so with like subtle nonverbal cues in particular. Whereas individuals with autism have trouble with both verbal and nonverbal cues. So this could be things like reading other people's facial expressions, picking up on sarcasm or humor or abstract concepts. Another area that we look at and consider too is their social interaction and participation. So like I mentioned before, individuals who have TBIs might be socially isolated for a variety of reasons. They may be in a rehab facility. They may not have been able to go to school due to the injury for a period of time. There may have also been times where, again, with autism, for example, some of their approaches are not well received by others, and that leads to then social rejection and withdrawal on their own. There's also certainly, a lot of people sometimes with who work with individuals with autism are always, saying that, You meet one child with autism, you've met one child with autism. And that is very, very apparent. And still to this day, I see kids with autism every week. No two presentations are alike. Certainly, a lot of individuals with autism, I feel like a common myth is that they have absolutely no interest in other people or interacting with others. And I've certainly seen to some degree some of that presentation, but there are so many kiddos who have autism who are so socially motivated and they truly do want to engage. And that's where we know there's more of a skills deficit or some kind of skills intervention that can be really helpful to show them different ways of kind of approaching others and interacting in more appropriate ways, depending on the abilities they have at that time. Which is why, certainly, for individuals who have TBI, for example, social skills training, social skills groups can be really helpful for them, in terms of regaining and learning some of these skills over time. Next slide, please. So we'll talk a little bit about some of our test findings on neuropsych profiles here. And I want to reiterate that these are some of the most common findings. These are not by any means the most consistent ones. Again, autism is a spectrum. TBI, there's so many factors, like Dr. Murphy said, in terms of presentation and how that can impact our findings as well. It's individual to the person coming in. So certainly, take these things with a grain of salt. But I think overall, big picture, these are some of the most common findings that we see. So with autism first, or I should say the first domain that we typically look at is intellectual functioning, IQ functioning, and this could run the gamut. We've seen all different presentations of individuals with autism who have very low functioning because autism is also commonly associated with intellectual disabilities. And similarly with TBI, again, depending on what part of the brain was impacted. What's unique to autism is that we commonly could see sometimes like a really much stronger nonverbal IQ. So like they may have really strong visual spatial skills or nonverbal reasoning. So looking at patterns and understanding patterns better than their verbal IQ. It doesn't necessarily mean that their verbal IQ is, really weak or below other kids their age. It could just be that there's a split where their nonverbal skills are superior or really, really well developed. In individuals with TBIs, a common finding on IQ testing is that their processing speed is impacted. Their novel problem-solving skills are impacted. And we look at academic abilities too, we tend to see sometimes this phonological processing, the sounding out of words can be really effortful for them, which brings us to the language piece, which is why with TBIs on our testing, some of the most common language findings are what we call an aphasia or dysnomia, where this is either the loss of the ability to understand or express speech, whether it's in writing or whether it's speaking, or dysnomia, not being able to kind of think of the words you want to say. You can probably describe it, but it's almost like that tip of the tongue phenomenon when you can't just tell me what the word is that you have in your mind. You can see the object, you can describe it to me using other words, but it's that difficulty with retrieving words from memory. In contrast, individuals with autism, this can also run the gamut. Individuals with autism can also have language impairments. They can have grammatical errors in their speech. They may also be verbally fluent, but it's more of this weakness with their verbal processing speed. It might take them a little bit longer to kind of get their thoughts out and put their thoughts together. But a common finding on both for individuals who present to us with autism and TBIs is weaknesses in their expressive skills to varying degrees and understanding social pragmatics. Now, non-verbally, a lot of times what we see common across both profiles is their ability to organize information. And a lot of that makes sense because when we think about executive functions, it's how we're making sense of information or material that's coming into us. And if we're thinking about non-verbal or visual spatial information, it's a lot of details to attend to. And that also then relates to why there might be some subtle weaknesses in what we're thinking about in terms of nonverbal cues. Where in autism, we see sometimes a lot more of these abilities that are much strongly developed in terms of their visual spatial skills. So their ability to kind of take information and kind of manipulate it with their hands and in their mind and reproduce things that they see visually. Whereas with TBI presentations, more often than not, the visual spatial or nonverbal deficit that we're seeing is kind of driven by something else, like an executive function deficit or an actual deficit or impairment in their spatial perception skills. So that's also something that we always kind of look into further. With motor across both presentations, they both very commonly have weaknesses in their coordination or balance skills, which is why one of the risk factors too for autism is accidental injuries, which puts them also at greater risk for TBIs. If they have a poor coordination and they have weak balance, they're more likely to trip or fall over themselves, and that can lead to them accidentally having a head injury. Uniquely to autism is, trouble with motor imitation. So sometimes we'll even have parents coming in, and when they're telling us about their toddler's development, they'll describe to us how they try to make facial expressions to their toddler, and their toddler is not mimicking them back. Again, that's something unique to autism, where that is part of that motor imitation part, and why in our assessments we ask about things like copying and imitation skills. Whereas with TBIs, it's more that there's this motor system damage. So what we'll see typically is like this decline in their psychomotor speed, which makes sense as to why their processing speed is so impaired. Next slide, please. In terms of attention, so just like Dr. Murphy said, it's not just one part of the brain or one function that we're talking about when we think about attention. It's multiple different aspects of it. But typically with autism, it's trouble kind of shifting attention or their focus away from something that they're doing or a task that they're on, or even an interest, which is why there could be some of these perseverations. Autism also very commonly co-occurs too with ADHD. A lot of times we'll see the two together, and it's a little bit hard to tease apart sometimes, but certainly this is one area that autism and ADHD overlap with that shifting ability. With TBIs, a lot of times they have trouble kind of multitasking in their mind. So sustaining their focus, just like Dr. Murphy said before, ignoring distractions. If you have to stay on task and keep focused on what you're doing, and at the same time ignore what's going on around you, that's essentially mental multitasking, and that could be really effortful for them. In presentations of TBI, you may also see secondary signs of ADHD. So it's not uncommon to have that as a secondary diagnosis after the injury occurred. With executive functions, again, a very general, broad term, but for the most part, the overlap between the two is this planning and organizational ability, this kind of shifting part as well in terms of flexibility and judgment, as well as impulse control. And certainly some of these things, when we're thinking about our daily life, can impact our social functioning. If we don't have appropriate impulse control, we're invading other people's spaces, we're blurting things out, that can impact how we interact with others from a social perspective. And then the last part is memory. And this can certainly, be impacted for a variety of reasons. There's a whole, I would say, spectrum too, in terms of what is impacted on each side. But on the TBI side, most difficulty comes with the encoding and retrieval part, which makes sense then related to those language skills. Whereas individuals with autism, a lot of times their recall for like just basic facts is awesome. But when it comes to more interpersonal content, like autobiographical information, much harder for them to recall. Next slide, please. Now, like I mentioned before, both are very closely tied to adaptive functions or skills. And like I mentioned before, our ability to perform everyday tasks with some level of independence and responsibility. And there's 3 different domains that go into adaptive functions. The first one is conceptual, and this is more of like the application of our academic skills. So things like language, communication, reading, writing, our judgment in different situations, problem-solving skills, and so forth. Next slide, please. And the next 2 domains are our social and practical abilities. So social, again, there's that common thread between the two, where this is our ability to have friendships or our social judgment in situations, being naive to, if individuals are trying to take advantage of us or people are trying to pull one over on us, trying to have that awareness. And then practical skills are more, I would say, of our very much day-to-day kind of abilities, where we're managing money as we get older, we're going to school, we're taking care of our homework. At the toddler level, these are things like you instruct a toddler to take out the trash. You give them a piece of, a napkin or something and say, go throw it in the garbage. Their ability to do that, but learning how to do it on their own, again, with that independence piece over time. Next slide, please. So things that we want to consider too, in this context are certainly, what an individual's intellectual and neurocognitive capacity is like, because adaptive functioning could be affected by ID. Adaptive functioning could be affected by executive dysfunction. If we're so disorganized, we can't keep track of paying our bills and we lose track of our money and whatnot, that can certainly have an impact. We want to also take into account an individual's educational history. Was there any educational neglect, a limited exposure to education that could have impacted some of their abilities in that domain? Other things like interpersonal factors, and that also relates very much with some of the mental health issues. If an individual is highly depressed, they're less likely, they may not be the ones to kind of take care of themselves. They may not shower every day. They may not change their clothes every day or get food. So certainly some of those adaptive abilities can be impacted for those other reasons apart from autism or a TBI alone. Now, the other thing too is certainly, in terms of when we think about other coexisting medical conditions, like we mentioned, seizures as well, this can also have an impact because they are at a higher risk of head injuries too. So we want to take that into consideration. Now, this kind of leads us into, certainly some of, if you go to the next slide, please, the most common outcomes in terms of, certainly like a social and a conceptual approach. A lot of times in terms of, like I mentioned before, with toddlers, a lot of the abilities that we're looking at developmentally are communication, both verbally and non-verbally. But research has shown that a lot of the toddlers who have sustained severe TBIs, the area of their adaptive functioning that's most severely impacted is the conceptual domain because of the communication part. A lot of times in individuals who have adaptives that are impacted with TBIs, the social domain is the one that's impacted, which is why it so closely overlaps with autism in that regard. Now, a lot of these adaptive weaknesses can certainly persist into adulthood, and I know Dr. Murphy touched on a few of these before, but again, it can really impact later on outcomes like higher unemployment rates and reduced quality of life, which if you please go to the next slide. These last two touch upon the mood part. So a lot of times depression, anxiety are secondary to individuals who sustain TBIs. A lot of things certainly can relate to, again, that context of the injury, how it occurred, what was the nature behind it, any residual traumatic reactions to it. Was this in the context of domestic violence? What triggers are around? And also even going forward, certainly in terms of, a medical perspective, a lot of kids in the pediatric population may already have this underlying anxiety about doctors already. And now if they sustain a TBI, that can heighten that anxiety as well. Sleep disruptions also are a big part, whether this is secondary to mood concerns or the injury, or even individuals with autism are known to have sleep difficulties as well. So if we go to the last slide in terms of how this presents then in autism and TBIs, again, a lot of overlap with the anxiety and depression piece. This could be, again, secondary to the injury, secondary to the circumstances or their differences or challenges they've had over the years in terms of interacting with peers and being in school and having these social differences. But what's unique then, certainly, like I said, for TBIs, for example, were they already anxious about doctors before the event? Are they more anxious now about medical procedures? Are they, more depressed about this reduced level of independence? So if this is somebody, let's say a teenager, for example, who, had some level of independence, sustained a TBI, and now they're so dependent on others, that can certainly impact their mood and functioning, which then can have an impact on their adaptives. The other part is how are they dealing with these emotions? How are they regulating themselves? So self-regulation difficulties are common in both populations. For TBIs, a lot of times this might come out more as like a verbal aggression, so a lot of yelling, irritability. We know already in autism, the population already has a higher risk of TBIs because of head injuries in terms of this could be either accidental, and one of those accidental injuries could be from a self-harm behavior, something like a head banging injury. So with head banging, for example, this could be because they're seeking out stimulation. This could be part of a repetitive routine, but a lot of times this could lead to mild TBIs, and they could be recurrent mild TBIs over time. So, there's no evidence to suggest that one causes the other in terms of, autism will always cause a TBI or a TBI is what causes autism. But certainly, our goal really was to show the overlap between the two and how it can manifest in different populations and how it presents on our testing. So I will turn it back over if Dr. Murphy has any closing remarks, but I think that was it for our presentation.
Absolutely. I think we have some time for some questions. If there's anything that people want us to kind of answer for them, clarify, anything like that.
Absolutely. Well, thank you so much for that really informative presentation. I know I learned a lot, and I'm sure everyone else did as well. So as you said, we do have some time for questions. Just looking at the chat, it looks like someone had asked about a change, if there's a change in the sympathetic and parasympathetic nervous systems due to brain injury, how does that play a role in neuropsychological factors such as executive functioning and cognitive functioning?
I mean, with respect to kind of disruptions in, any of our nervous system functioning, we're going to anticipate that either, kind of again, sort of in the most straightforward way that, because this could be a presentation in of itself, Either we're going to be overly reactive to kind of stimulation in our environment or underreactive. And so what that could look like is it could look like dysregulation with respect to maybe like big behavioral reactions to seemingly benign things in our environment, sounds, experiences, things not going our way. Or we might have real significant underreactivity, things that should elicit, fear, anxiety, or, even like just awareness and kind of like base level arousal. We might essentially just see that an individual is not really having that kind of reaction. And in daily life, that could be, not recognizing, a sense of urgency for things like this. The idea of, oh, is this person, let's say, not recognizing why it's important to pay our bills or take care of themselves or any of these other things that again, could result in disruptions in daily life.
Absolutely. Thank you. Thanks for that response. We have another question about the interception or the interlap between OCD and TBI and kind of what that might look like, what that intersection might look like. Could you speak a little bit to that?
Yeah, it's another good question because we know that the phenomenon of something like perseveration, kind of getting stuck on something, is, an element of our executive functioning skills. Like there's a particular area of the brain, the basal ganglia, that tends to kind of be really good at like, describing patterns or like kind of getting used to things, but it's also very good at stopping us when, let's say, like, we don't want to engage in a behavior or behavior isn't necessary anymore. And so depending on the nature of the injury, we can see elements of just kind of more general anxiety, or we could see some symptomatology that looks a lot like OCD. Now, again, it can potentially be kind of like biological in nature, potentially there's a very focal injury to that area of the brain, and there's sort of like this new onset of this, but it's another condition where, because of the nature of when we expect it to manifest, like for a lot of people, it can start a little bit in childhood, and it kind of, we think about it almost like kind of relapsing and remitting throughout their lives. Like all of a sudden they'll have a flare, then it kind of goes away, and then it flares and it goes away. It can be really hard to say, is it like kind of a temporal association or is it due to the actual head injury? It can be really hard. And again, that's where like potentially a good family history can come out. In some instances, it may not change what we would recommend. So we might say, listen, regardless, I want you to have like exposure and response prevention. Maybe we might adjust if we feel like, it's more of like a perseverative, kind of biological thing. We might talk a little bit about medication or some other options, but it might not necessarily change how we would treat it. So we might use the term OCD and say, like, whether it's due to the injury or not, this is what it looks like. And we know what works best for this population.
Okay, great. Thank you. And then someone had asked about perfectionism as a restrictive behavior. So what role that might play after brain injury and kind of how it might interfere with treatment in certain ways.
Dr. Spraza, do you want to? I know we've talked a lot about, kind of perfectionism within the practice, things like that. So I'd love to sort of hear your thoughts on this too.
Yeah, absolutely. I think it certainly can tie in very closely to OCD, so a formal diagnosis of OCD, for example, and it also can tie in as like a restrictive behavior related to autism. We see it most commonly too in females, especially. A lot of individuals, like going back to the head banging example for while we were on that one. What came to mind is certainly, individuals can be compelled or feel like they have this compulsion of self-harm or that they don't deserve something, and that can manifest as a self-harm behavior, one of which could be headbanging, which puts them at that increased risk. In terms of, having this perfectionism or having these self-injurious behaviors, that can absolutely interfere with treatment. So with regards to treatment, having to have things done perfectly, that's really kind of hard to tolerate, and that's hard to work around, especially with that rigidity. A lot of times what is recommended is what's called exposure response prevention, where what we're doing is we're essentially, exposing individuals to the triggers of their compulsion. So whether it's a trigger for self-harm, whether it's a trigger that provokes this need or compulsion to be perfect or perform something perfectly. And over time, we gradually expose them to that and help them kind of learn how to tolerate that distress in the moment, while also giving them different tools or adaptive skills and abilities to replace the behavior that's, not as effective or not as adaptive in that moment. Sometimes, especially there might be what we call like this behavior burst at the beginning where things get a little worse before they get better. Sometimes strategies and treatment could also include things like using a helmet or other, interventions or kind of things to help kind of until behaviors are basically, able to get stabilized over time. But it certainly can be a bumpy ride. It's not going to be something that's very straightforward and is the same as everyone who presents with perfectionism, for example. But I think having a really good clinician who is well versed and specializes in this area specifically, I would say, is really the key.
Absolutely. Thank you so much. And then someone had asked about the role of medications in the treatment of TBI and ADHD, or some of these kind of overlapping or secondary diagnoses.
So we should probably, and I always have this kind of caveat, broad statement of like, because we are PhDs, we do not prescribe. And so it's a very good question to be, asked of a physician, a neurologist, or another individual, a psychiatrist who may be very well versed in this. Again, it good route for treatment. We know that there are, certain symptoms, whether it's impulse regulation or just like the broad attention more generally, that sometimes respond a little bit better or a little bit worse to medication. So that is certainly still something that can be prescribed. It's not unusual to see individuals, particularly when they talk about, difficulties maintaining, long periods of focus or even sometimes a lot of the fatigue that can happen, to be prescribed a given medication or stimulant to be able to function throughout the day. But it really is a case by case basis, because there can be instances like kind of co-occurring anxiety, let's say, that might, complicate it, where the use of a certain medication we would use to control attention might actually exacerbate that anxiety, and we want to avoid that at all costs. So it sort of is a case by case, but it absolutely can sometimes be a very helpful tool.
Absolutely. Thank you.
Mhm.
And then I see someone else in the chat asked what education and kind of self-advocacy can be done, because they feel like, some doctors, attorneys, etc., might not have this knowledge of TBI or autism. So kind of how can someone help advocate for themselves and spread this education?
Oh, that's a good, systemic question. Um,
I
you
could say the
know,
first thing that came to
yeah,
mind for me is collaboration.
yeah.
I think the biggest piece is like having medical providers collaborating with families, collaborating with school staff directly too, as much as possible. So this way everyone's on the same page, things are consistent to make it as easy as possible for a child who already has these challenges that they're experiencing going forward. So I think that was the first thing that came to mind for me, Dr. Murphy. I don't know from your experience if you have something else.
I would agree. I would think, in terms of, kind of being knowledgeable, again, kind of connecting people as much as humanly possible. We do certainly get referrals from lawyers. We do occasionally get, requests from lawyers or clients who are involved in some form of, legal process with the school or with, other things. And we will talk a lot about, and sometimes, like with permission, sort of discuss some of our findings and why we are saying one thing rather than another. Again, I think it's unfortunately, an issue that it can be hard on an individual basis, just simply because like we're all limited by time, again, like a person's willingness to listen to us. So that a collaboration, I think, and just kind of ongoing push for continued education, is really one of the best ways for a clinician or like a lawyer or whomever it may be to be aware of and open to these things.
Absolutely. I love that answer. And then someone else in the chat had asked about your offices and services, where you're located, and if you're connected with the TBI fund, if you do reasonable accommodations, return to work, kind of like what's the scope of your services and where are you located?
Great question. So both Dr. Spraza and I are at the Wall Township location of Neuroabilities. We also have kind of testing offices in Voorhees Town Center in New Jersey. We have another office out in King of Prussia. We have not just sort of like our medical services, and that includes us as neuropsychologists. It includes our physicians, who are comprised of neurologists, developmental pediatricians. We have psychiatric AP mental APNs. We also have a wing of ABA services, because we are primarily a neurodevelopmental clinic. So we do tend to see kind of children and adolescents and like very young kind of college age adults. Certainly TBI, things like that, that can be a part of kind of our evaluation process. We can talk about, accommodations, but we really specialize in kind of working with children. So I always say like that's one of the big kind of things, but certainly we've had, kind of cases and questions of TBI, whether it ranges from the kind of like more mild or kind of more moderate to severe injuries. Generally, our process is that individuals will see one of our physicians. They'll have a neurological or kind of developmental evaluation through them. And if that physician feels that a neuropsychological assessment is warranted, they'll put an order in, and then you see somebody in the practice. And what's nice is that kind of we collaborate together. We're a pretty close group. So there's a lot of information about us kind of on our website. But certainly, yes, like that's something that we do to the best of our ability.
Great. Thank you so much.
Absolutely.
And then I see a couple questions about the survey. So we will be putting that in the chat, Chris, if you don't mind putting that in the chat. And it'll also be sent out after as part of the follow-up. So keep an eye out for that. And it looks like, someone asked if it will be available. So the recording will be available on our website. And otherwise, thank you both so much for that really informative webinar today. If anyone's question was not answered, you can reach out to me at kmyers@bianj.org, and I will try to have our presenters answer it. So one final email, please complete the survey that is now in the chat. So you can go ahead and click on that, and you will receive a certificate of attendance once you complete that. So thank you everyone for attending. Thank you for all the thoughtful questions, comments, and we hope to see everyone at the May 19th webinar. So that concludes today's webinar. Thank you again.
Thanks so much. Have a great day, everybody.